Okay, we start in about 10 minutes.
For how much I've had to drink. And it's white flag.
Let me take off this starting soon. Mhm, mhm. Greetings, Jeremy. Are you in the panel there?
Hi, John. Yes,
Hey, hello. Who's this?
Jeremy.
Oh, hi, Jeremy. How you doing?
I'm fine, John. How are you?
Good.
Okay.
Good. You're a frequent visitor, right?
Yes, I'm a frequent visitor.
Now, where are you? I probably asked you before. Where are you from, Jeremy?
I'm from Kenya. I'm a
Good.
neurosurgery resident from Kenya.
Very good.
Yes.
Anytime you're ready to do Kenya Grand Rounds, let us know.
All right. Thank you very much. I will.
Yeah, get together with a couple of your buddies and do a presentation or two, just like this. We do it every 2 weeks.
Okay. I'll be sure to tell you when you have one.
Yeah, well, just let your associates know that we'd like to do it.
All right.
We do it now in Venezuela, Nicaragua, pretty regularly.
Okay.
We'll pick up others along the way.
All right.
France did it for a while, but they backed off. Then there's a couple others that are kind of like Cuba is coming back, I think,
Okay.
because no one does these for free on the internet.
It's true.
The
It's
state
true.
societies don't, pay. And so they don't want to pay people to do webcasts. The medical societies, the neurosurgery society. I think they should do it
I agree with you. It's true.
because the money you guys pay, you don't pay a lot, but the money, the dues that you pay should be for education. How much do you guys pay something to get belong to the Kenya Neurosurgical Association?
Oh,
You
yes.
you have dues, probably not a lot.
Not so much, especially if you're a resident. The cost is usually
Yeah, like $50, something like that, maybe $25.
Yeah.
And I think that you should use that money for education, because now there's not as many state societies aren't putting on conferences because it's expensive, especially after they've seen Zoom. They say, we don't need to have a conference, we'll do it in Zoom, but we don't want to pay for Zoom.
Yes. So you prefer to use Google Meet, especially because Google Meet is usually free. So most of the time, that's what we use to host our meetings.
Oh, what kind of meetings did you say they use?
The Google Meet from the Gmail.
Oh, okay, Google Meet, right.
Yes,
Yeah, let me
Google.
check on what's going on here. Okay, I just talked to Sarat. He's on his way in. Okay, just a few minutes. Okay. I'll write him again saying, let's go. What time is it IST there? Am I early? Is this early? What time? Could you please answer me, panel? Text me. And let me know, please. Oh my God. Yeah, you're right. Yeah, it starts in 40 minutes. Okay. Yeah, I was wrong about the time. It is Sarath. I was wrong about the time. I'm an hour early. Well, it's better than being like 1 hour late.
Can you hear me, John?
Yes. Hey, how you doing, Sarath?
Yeah, I'm good. Can you give me? You got
I
the
don't
time
know
for
why I made that mistake. Usually I don't with IST. Did
Yeah.
you guys just have a time change or something?
No, not really.
Maybe. Okay, I don't know. Because it's not. This is, yeah, 9.5 hours, right? Yeah, right. Man, mental calculation.
No. John, can you give me 10 minutes? I will
Yeah,
join
no
the
hurry. Yeah, we got lots of time. We have 30 minutes. I
Okay,
didn't
okay.
realize.
Give,
I didn't
give me 10
realize.
minutes. Right, I'll
Okay.
come back. Thank you.
Okay.
Bye.
And tell Sharaf to come in. He wants to come in to
Yeah,
check it, right?
yeah. Sure. I'll come back. Right. Okay.
Okay. Hmm. Okay, Prasanna and Samuel, we start in 30 minutes, okay?
All right. Thanks.
Okay,
Very
So-
good. Okay.
we'll join in 30 minutes time.
Okay, we'll be here.
Okay, we'll join at in a half an hour.
Yeah, maybe a few minutes before.
All right. Thank
That's
you.
when we hand out gifts.
All right.
Okay, see you in a while.
Dr. Surat? Yes, I have logged on. And I have got the start. I'm getting the screen starting soon.
You have to change.
No, the what?
Hi, can you hear me?
Yeah. Now I can hear you.
Okay, good.
President,
Is
John,
yeah, hi, you want to go over your presentation?
can you see us?
Yeah, no, I cannot. Can you see you?
My video is on.
Video is on. Can
Yeah, your YouTube's also on, I think. Oh, let me see here. Hold on. Okay. Let me make sure my YouTube is off.
No,
Okay,
I
there you
can
go,
see you,
Sarat.
Dr.
I can see Sarat. Yeah, someone's got a YouTube on.
John, can you hear me?
Yes, I can hear you fine.
I think what happened, John, actually, I have forwarded my email to Dr. Suresh. I think he has logged with that. So that's why it shows my name. I mean, in the panelist.
Do you want me to do you want to send me the different one link?
John, can you actually send me the email?
No, I can put it in LinkedIn though. What do you want?
Can you send the link to Dr. Suresh?
Yeah, you can too. It's in your, I sent it to you, so.
No, the thing is actually he wanted to through the email. That's why.
Oh, okay.
Because he's logging from the computer.
Okay, where's his email?
Give me 1 second. I'll
Yeah,
send it to you.
I think you gave it to me. I think you. Yeah, I think you gave it to me here on your LinkedIn account.
I have sent it to you, John. Yeah, I just sent it to you.
Oh, okay.
I think what Dr. Suresh can do, I think you can log out. And you can
okay.
Yeah, you can log out
yes.
and you log in with the new
fine, that's fine.
Well, no, stay there. No, I think I just haven't admitted you from the panel. Okay, hold on. Oh, okay, you're not even in the panel, but why can I hear him? Why should I hear him? I don't understand. Okay, whatever. Okay, let me send him to that email. Okay. Okay, he's getting the email now.
All right. It's great.
How you been?
Yeah, I'm good. How are you?
Busy? Yeah, you're not working tonight though, right?
Yeah.
Tonight. Are you on call?
I'm 24/7 on call, John.
Oh, wow, okay. That's right, you have no partners, right? You work solo.
Yeah. Today
Yeah,
it was
I-
actually a bit busy. That's why I got a bit late to get
Oh,
back
okay.
to home.
Yeah, I
So
was wondering, I said, this isn't like him, he's an hour late. But,
yeah, that's why I was wondering.
Yeah, well, actually, there were some people, and there were more, like, not 4 or 5 people, I guess they made the mistake too. Because when I send out emails, I say 1 hour,
Mhm.
hour and a half, and tell people, what happened? Where did you go?
Is that so? Did your time change? Time zone? No, I don't
No,
think so.
no, it was just I got it wrong.
Yeah.
You know, like 9, as I knew it was 9.5 hours, but for some reason I thought, oh, that's 10:30, but no, it's 11:30 here.
Okay,
Yeah, he's here now.
right.
Is my camera working okay?
We cannot see you, John.
Yeah, I'm wondering what's going on here. Yeah, oh, wait a minute. Okay, hold on.
Sure.
There we go.
Yeah, now we can see you.
Okay.
And Dr. Suresh is here, so we can just check the presentation.
Can you see me?
Yeah, no, we cannot see you,
Not yet, not yet.
but we can hear you.
I can see you, but I can't.
Yeah, you turn your camera on.
Yeah, your camera is on.
I'm turning my camera off, but I can't.
No, I
can you-
think, John, you have to bring him as a panelist.
No.
That's,
Can you see
Yeah.
me now?
I can see my name, but I can't see my picture.
No, I can't see. The video's acting strange. It's not. I can't see myself. On
No,
the-
I
I
can
think,
see you. We can see. We can see you.
No, you can't see me, right, Sarah?
no, John, I think actually he's logged in as an attendee. I think just promote him to a panelist.
Okay, I'm gonna leave then, okay?
Yeah.
Okay, you should be fine. I'm gonna sign. No.
Sarath,
Dr.
do I need
Suresh?
to? Do I need to log log off and come back again?
No. I think John has got some problems, Dr. Suresh.
That's why I
just
told you we should start half an hour early.
no, I think this is the first time actually it happened to him. Don't know what's
Okay.
going on. So we'll just hold on. So he'll come back. I think actually, I think he wants you. I mean, you should be. I mean, logged in as a panelist because I can see you're just an attendee. That's why you can't switch on your camera. That's the thing.
Okay. That's right. Okay.
What's happening, John?
I don't know. I don't know what's going on here. But I just gotta work through it. Let me try to leave again. Well, thing is, like, I don't know what's going on, man. On settings here. Yeah, it looks fine. Now. Looks fine there. Yep. Okay, let me check. Oh, look, it's working. The camera's working itself. The transmission to the Zoom. Going to the Zoom, but it's not going to the screen. Yeah, I can see it in my screen, but let me keep playing with it. Oh, okay. Can you see it now?
Yeah, of course. Now we can see clearly.
Okay, now if I remove the spotlight, look at that. I'll just have to spotlight myself when I talk. And turn it off. Turn it off. Okay, remove spotlight. Yeah, something seriously wrong here. Set. I rebooted. I'll figure it out sooner or later. I may have to. I'm gonna leave and reboot, and I'll be back.
Sure.
I'm gonna download another Zoom. I'm gonna assign you. Oh. Make host. Okay, you're the host now, okay?
Okay. John, is it possible to bring Dr. Suresh as a panelist? Is it possible now?
Yeah, no problem with him. Okay, yeah, there he is. I don't know if he's even connected. Apparently it looks like he's not connected.
No, he's there. He's an
Yeah, I
attendee.
know, but there's no option for me to let him in.
Oh,
That's unusual too. Something's wrong with this. Something's wrong with this. I have options for everybody else, but not him. Something's corrupt here. There's gotta be a virus or something. Okay, I'll be back.
sure. Dr. Suresh, can you share your screen? Is it possible? Is that option is there for you?
No.
No, you can't share the
No,
screen.
I
is it?
think I have not been added as a panelist.
Yeah, that's the thing.
So
Mm. Is it possible for you to log out and rejoin?
me?
Yeah. Shall we try?
Okay. I'll log out. Okay.
Yeah,
I'll
log
log
out
out.
and rejoin. Yeah, sure.
Okay, fine.
Okay. Dr. Suresh, can you hear me now? Okay, fine.
Can you hear me?
Yeah. I have promoted you as a panelist. Now I think you should be fine.
Surat.
Yes.
Okay. Now that.
Right. Now you can share the screen and we
Okay,
can
no
have a
problem.
trial run. Yeah.
Right. I'll share the screen.
Sure, yes. Hi,
Shall
John.
I
Are
share
you?
the screen?
Yeah, sure. You can share the screen. Yeah. Let's just check it.
Are you seeing the screen?
Yes.
Are you seeing?
Yeah, we can see clearly.
Okay. I'll just play the video. The rest of it is
Sure.
no
Yeah.
issue. Yeah. Are you seeing the slides,
Yes.
Surat?
Yeah, yeah, yeah.
Mr. John?
Yeah. Yeah, we can see. Nice.
Surat and
Yes.
Mr. John, can you see the video?
John, actually, we can't hear you. We can see the video, Dr. Suresh.
Okay, it is clear.
Yeah, it's clear. Have you played it, or it's just like slow motion?
I'm playing it now.
Right. Just play it.
It's a slow motion, is it? Okay.
Yes.
Clear?
Can you hear me now? Can you hear me now? Yeah, now you-
Yes, John. We can hear you. Yeah.
Yes, I
yeah,
can hear.
right.
Okay.
Yeah, now it's playing. Yeah, it's playing, but it's a little bit slower than
Okay.
the average speed.
No. Haha. Okay.
You have a good website there, Suresh.
Sorry.
You have a good website.
Sorry.
You have a
Hello?
good website. You can't hear me well? You can't
Yeah.
hear-
Yes, I can hear you.
Okay.
Can you see the video?
That's a video, okay. It looks like a really big enlargement. Is there any way you can decrease the size of the video? You know what I mean? It's no big deal. You can still see it. Like a more distant view. The video looks really big. Do you know what I mean? Like it looks like it's 120% or 150%.
Mm. Yeah.
You know what I mean, Suresh?
Yeah, I can understand.
Right. Yeah, we got a few minutes to work on it. You know what I'm saying, right, Suresh?
Dr. Suresh, can you hear me?
Oop, looks like he dropped off.
I think his internet connection is not stable, is it?
Yeah, that's usually what happened, what it means. I just did I tried to do a conference from Venezuela
Oh,
this morning, but we just couldn't connect.
okay.
The bandwidth was just not good enough. And there's all, the audio has problems, the video has problems. When the bandwidth is low, you
Right.
don't get away with anything.
Yeah, that's right.
So you really gotta have everything set up. Okay, Sharat, do you hear me?
Yeah.
Okay. You want to get a good background, get like a picture of India, a picture of your neighborhood? Suresh?
Yeah.
Yeah, okay, that looks good.
Oh, that looks good. Yes.
Yeah, that looks good. I know what
Yes.
you did. Yeah, looks good.
Yeah.
Now make it full screen, please. Make it presentation mode.
That's okay.
No, it's not okay. It's not presentation mode.
Go to the slideshow.
Now you see. Now you see. Now you see.
Okay.
It's okay.
No.
Not yet. Not yet. Not yet.
There you go.
All right. Yeah.
There you go.
Yeah.
Yep, that's better. Now it's clearer.
Okay. Thank you. Thank you. No, I changed my Wi-Fi settings. I went to a high definition video.
Okay.
Right. Right. That's great.
Yeah, we're gonna try our best, Sarath, but your connection
Sure.
looks pretty low.
Yeah.
Of course, we're gonna try our best.
Sure.
Okay, I'm gonna ask you to do something for me, Sarath. I want
Yeah.
you to go to this website.
Sure.
Speed. Yes. Can you go to this website, Suresh? And run the test on your computer?
Dr. Suresh, can you open
you
the
see-
chat box and go to this website, www.speedtest.net.
So I'll stop it.
No, just open the link. Just open the
No,
link.
just open the
Okay,
link.
Speed
Yeah.
test.
Just open the
I'll
link.
open that website.
That's right. Yeah.
Open the
Yeah.
website and take the test for your computer. Put on.
No, www speed test. Okay.
Speed
Now what I'll
test
do
dot
that.
Go there.
I got it. Yeah. What should one would do?
Go there.
I'm sorry.
Can you go there? Just click the link.
I clicked on the link, but it's not opening.
Okay, so copy and paste it somewhere. You're not going to leave the webinar by doing that.
Okay, I'll do it
Can you-
again.
Can
Okay.
you copy and paste that?
Oh, where you want me to paste?
And minimize the webinar.
Okay.
Don't leave it, just minimize it. And go to that.
Okay.
link.
Okay. I'm not getting it.
Okay, don't worry about it. Let's not we're gonna have to make a big deal of it. It's okay.
Okay.
Maybe later we'll do it.
All right. No problem.
Okay, but
No. I'll stop sharing.
yes,
Yeah.
yes. Okay,
I'll stop.
I need to give you instructions. Okay,
Okay.
on using a low bandwidth. Okay, now when you're doing the presentation like you are now, I
Yeah.
want you to turn off your video screen. Like I'm gonna do it now.
Okay.
See,
Fine.
Your
I got
video,
it. Yeah. I'll do it.
because that conserves bandwidth.
Right.
Okay.
Right.
I want
Yeah.
you to do it now. I want you to turn off your video, stop video. I want you to
Okay.
do that. Do that now, okay?
Okay.
I want to see you do it.
Uh,
On your menu, just click on the camera and it'll, your video, your little picture will go off.
I know.
When you take that off, it conserves bandwidth. You took
I
the
get it, I
audio,
get it.
now take the video off. There you go. Can you hear me okay? Hello, can you hear me okay?
I stopped my video.
Yeah. can you hear us, Dr.
Can
Suresh?
you can you hear me
Yes,
okay?
Surat.
Okay.
I can hear
You see how it is now?
Yes,
That's what I want you to do because it conserves bandwidth.
right.
Yeah,
No,
so-
yeah, we'll do
So,
that. No
of course,
problem.
when we introduce you, I want to
Yes,
see
all
your
right.
camera on, okay? When we
Yeah.
introduce you.
That's right.
And-
Okay, that's fine.
And Sarath will do the introducing.
Yeah.
Yes.
So you can stop sharing, Dr. Suresh.
Yeah,
Okay,
Right. Thank you.
yeah.
okay, ready to go. There'll be people joining us along. Okay, 10, 9,
Right.
8, 7, 6, 5, 4, 3, 2. Good morning from beautiful Miami Beach, home of Neurosurgical TV. We have the pleasure of having Sarath Munasinghe, a neurosurgeon from Sri Lanka, who's done these webcasts for a long time. He likes the webcast. And today, he has a guest, Suresh Dugani, a neurosurgeon that I'm going to let Sarath introduce properly as a neurosurgeon. Welcome, Sarath.
Thank you very much, John. Welcome to another episode of Sri Lanka Neurosurgery Grand Round. So good morning, good evening, good afternoon, wherever you are. So today is a special day to us because we have got a very special guest today. And I think he's well known all over the world and especially in India. And he's Dr. Suresh Dugani. One of the popular and well-renowned neurosurgeons, and he's running his own webcasts as well as publishing neurosurgical videos for a long time. So he's a neurosurgeon from Karnataka, India, and he's working in International Neuroscience Center in Hubali. So I'm very grateful, and it's been a great honor to have Dr. Suresh Dugani for Sri Lankan Neurosurgery Grand Rounds. And I welcome Dr. Suresh Dugani to our presentation today. So today we'll be talking about mainly on olfactory groove meningiomas, and as well as, if we, depending on the time, we talk about the falcine meningiomas as well. Welcome on board, Dr. Suresh.
Thank you, Surat, and thank you, Mr. John. It's indeed an honor and a pleasure to be with you and share and learn from each other. And hello to all the participants and delegates. It's indeed a great honor. Thank you very much, Surat, and thank you very much, Mr. John Bennett.
Right. Thank you, Dr. Suresh. So today, as usual, so I'll be start talking on a few technical points on olfactory groove meningioma, and then we'll go to the videos, and the expert opinion will be provided by Dr. Dugani. So so let me start with my presentation. Right. Am I audible and visible, John?
Yes.
Right. Great.
Yes.
Right. So today the topic is mainly regarding the technical aspects, the challenges and technical nuances of olfactory groove meningioma and the parafalcine meningioma. So it's going to be a very interactive discussion. So if you have any questions, you can always interrupt us and ask questions. So it's a very brief presentation actually, so I will try to make this very concise. So we all know the olfactory groove meningiomas, they account roughly around 10% of all the intracranial meningiomas. There are certain special characteristics. It's a unique tumor because the clinical presentation, the findings, and most of the things are unique, and it remains a challenge for neurosurgeons to completely resect these olfactory groove meningiomas. So we know complete surgical resection is critical to prevent the recurrence. And although we talk about few approaches, numerous approaches, no single best surgical approach exists. And we know that it's complementary rather than mutually exclusive. So we'll be talking about these approaches very soon. So more about characteristics. We know it arises in the midline from the cribriform, in the region of the cribriform plate and the frontosphenoid suture, and it can extend from all the way from the crista galli to the planum. Although it arises in the midline, it often have a tendency to extend unilaterally as well. So the differential diagnosis is very important in these areas. So a neurosurgeon should be able to differentiate what it is, whether it's a more ventral olfactory groove meningioma or a dorsally placed planum sphenoidale or a tuberculum cellum meningioma. So as we know the relationship to the optic nerves and the chiasm. So these are bread and butter for a neurosurgeon, all the neurosurgeons. So the classification, we know the classification we can classify into small, medium, large, or giant, depending on the size. So as I said, the yellow, the olfactory groove meningiomas and dorsally placed planum or the tuberculum cellum meningiomas. So the differentiation is very important. So these are few differences between the two categories. So we all know this, the optic apparatus in olfactory groove meningiomas, it's inferolateral, but in tuberculum cellum meningiomas, in superolateral. There are other differences as well with regard to the blood supply, the olfactory nerves, the visual field deficits, and also the surrounding critical vascular structures. So as I said, usually the planum meningiomas, usually they present with early stages. They present at early stages with visual defects, but olfactory groove meningiomas, as we know, they can reach large sizes, and usually they present late, and they can extend into the paranasal sinuses and nasal cavity. I'm sure Dr. Dugani will talk about these, and he will show you the examples in detail. So we'll talk about that later with the videos as well. So some important points regarding the blood supply. So mainly derives blood supply from the anterior and the posterior ethmoidal arteries, but also there are other branches as well. And remember, the encasement of the vascular structures is not uncommon. So that's one of the challenges we face as neurosurgeons in large tumors. And the most common artery to be encased is the A2 segment of the anterior cerebral artery. But as we know, all the anterior cerebral vasculature can be nearby, and even the anterior communicating artery can be encountered. So these are few facts for us to know. In small tumors, most of the time, the anterior cerebral artery branches are separated from the tumor by a rim of tissue, arachnoid and cerebral tissue. But the problem is in large tumors, because they may adhere to mainly the posterior and superior tumor capsule. So the challenge is at the posterior and superior most region of the tumor. So you have to be very careful in large tumors when you reach the posterior and the superior surface. Right. So we had to remember as well. We had to remember also that the orbitofrontal and the frontopolar branches sometimes may become incorporated with the tumor capsule as well. These are the challenges. So just talk about symptoms. As I told you, the symptoms are usually of gradual onset, and it's usually underestimated. As I said, these tumors tend to grow slowly, and they gradually compress the frontal lobes. So patients can present with frontal lobe manifestations, which are the most frequent, sometimes with personality changes, and sometimes we see even patients with psychiatric symptoms often present to the psychiatric clinic. Sometimes we have found these large tumors in them. So they present with headache, alteration of olfaction, visual disturbances, as I said, and rarely Foster-Kennedy syndrome. Although we talk about Foster-Kennedy syndrome, it is a bit uncommonly seen in olfactory groove meningiomas. Sorry. So these are the few examples in my practice, and these are large giant tumors which presented to me, which I have operated few years back. So you can see these patients presenting with, this patient presented with psychiatric problems as well as headache, and she found to have a large olfactory groove meningioma. Another case, again, headache and seizures and visual disturbances, again, a giant tumor, more than 6 centimeters. Another case, again, more than 6 centimeters. So these are the, all the symptoms that I have mentioned here. So you can see anosmia, visual loss, headache, vertigo, depression, aphasia, etc., etc. Right. So these are the things that we are going to talk mainly as neurosurgeons. Patients present with visual defects. So the optic nerves are compressed and nearby, so we need to preserve these structures. So as we all know, these tumors extend posteriorly and inferiorly to compress the optic nerves, and they can cause inferior visual defect. In contrast to the bitemporal visual fields usually caused by the tuberculum cell meningiomas. So we talk about olfaction. It's very important always to try to preserve olfaction, but we know practically it's not always possible. And most of the people, they do not identify anosmia as a symptom or as a problem, because it develops slowly. And the olfactory nerves are usually displaced laterally by these tumors. Sometimes in large or giant or meningiomas, the olfactory tracts are invaded or destroyed on both sides. So the preservation of olfaction may be impossible. But we know in small lesions, we have a good chance to preserve. But we have to remember that anatomical preservation per se does not imply the functional preservation of olfaction, because sometimes we preserve it anatomically, but the function is not there post-operatively that we have experienced. Few facts about hyperostosis of the bone. So we have seen hyperostosis in few cases. Not in few cases, actually it's a common thing. So they erode the skull base and extend to the nasal cavities, paranasal sinuses, and orbits. In these type of cases, we might need to go for the extended approaches such as transbasal approaches. So a few things about preoperative imaging. As we all know, the diagnostic method of choice, the method is MRI. And we do MRI to see these characteristics to delineate the tumor and to look for the characteristics. Surgical planning is essential for vascular encasement. And we do the CT scans as well, which shows involvement of the skull base. So as I said, we can see the paranasal sinus involvement, the location of the optic chiasm, and also the vasculature, the relationship of the relationship of the critical blood vessels to the tumor, and whether the tumor extending into the cella. So all these things, and also the amount of frontal lobe edema, which is important, which have implications post-operatively, which correlates with the extent of the bile blood supply. So this is the preoperative evaluation wherever you are, whether you are in a developed country or a developing country, whatever it is, it's as a neurosurgeon, it's your responsibility to operate, to evaluate preoperatively. So these are the things that you need to look for. As I said, in a nutshell, the size and extent, the presence of bile invasion, vascular encasement, hyperostosis, extent of frontal lobe edema, and also the hemodynamic and the metabolic characteristics of the tumor. So goals of surgery, we need to consider both the tumor and the patient characteristics. So as I said, we talked about this. The patient characteristics also we need to consider. And these are the fundamental aspects to achieve good results, to achieve a good outcome. So the surgical experience of the neurosurgeon, multidisciplinary approach is always better. We need to have adequate instruments, appropriate patient selection, and thorough preoperative planning. So in meningiomas, we always try to achieve a Simpson grade 1 resection. So in olfactory groove meningiomas, it can be achieved in most cases. And we need to preserve the neurological function, avoid complications, achieve a good cosmetic outcome as well. So few facts about preoperative embolization. It's mentioned in the literature, it's mentioned in the textbooks, but we know nowadays I don't think we use it very commonly because of very few reasons, because of the technical difficulty as well as there's a risk of blindness. So I haven't in my setup, we don't have facilities for preoperative embolization, but we know it's not very common nowadays. So this is the most important aspect that we are going to talk about today. So these are the approaches. There are a few approaches for olfactory groove meningiomas, as we all know. So subfrontal, anterolateral axis, which is mainly pterional, combination of pterional and subfrontal, or lateral axis to the pterional, or endoscopic endonasal approach, which is very common nowadays. But currently, the meta-analysis shows there is no difference in tumor size, grade of resection, or complication among the different approaches, it seems. So whatever it is, the best surgical approach, it provides a more direct access and early access to the nourishing vessels. It should achieve a wide exposure. It should provide a convenient exposure, and especially for the skull base, anterior skull base, especially if we are doing for a reconstruction when the skull base is involved. And also it should minimize the brain retraction and the manipulation of critical neurovascular structures. Always, as a neurosurgeon, think about these facts. Think about the pile invasion, think about vascular encasement, think about frontal lobes, think about the optic apparatus, and think about your experience and familiarity with the different approaches before selecting your choice of approach. So this is the key maneuvers. I'm not going to go into details. So we all know about this. So this is the subfrontal approach. Usually we prefer the subfrontal the approach in large tumors or giant tumors. And in small or moderately large tumors, we prefer to go with the pterional craniotomy, pterional approach. But it depends. It depends. Even I have seen neurosurgeons going for the pterional approach, even for the large or giant meningiomas, olfactory groove meningiomas. So this is the technical aspects. So I'm not going to go into details again. So we all know these things. There are certain things that we need to keep in mind. So we have to be careful about the superior sagittal sinus and think about the frontal sinus. You enter the frontal sinus, you cranialize it. Orbital osteotomies, we rarely use, we rarely do nowadays. So even though it's mentioned, I don't think we use it commonly. Even there is skull base, I mean, there is involvement in the base, and it's very rarely when there is invasion to the paranasal sinuses and the ethmoidal sinus, the ethmoid sinus and the sphenoid sinus, we use these transbasal approaches. Right, so these are some operative notes. So as we know, so I'm sure Dr. Dugani will talk about these things, opening the basal cisterns, drain CSF, make the brain relax, which are very important. Gently manipulate the frontal lobes. It's very important, preventing damage to frontal lobe because of prolonged retraction as well as iatrogenic damage. So usually we know there's a plane of cleavage between the arachnoid and the tumor capsule most of the time. Right, so initial devascularization, sometimes we can, small tumors, we can directly go to the origin and we can devascularize, but most of the times in large tumors, we usually debulk initially and then go to devascularize. So devascularize, debulk, dissect. So, I mean, all of these are basic principles in meningioma excision. And right, so always sharp dissection is preferable. And we had to remember that the dissection of the posterior part of the meningioma, the posterior superior aspect, close relation to the anterior cerebral artery complex. So it's very important. So we always need to, as I said, we always need to make sure the end passage arteries, end passage blood vessels, as well as blood vessels supplying the tumor. We had to differentiate between the two. Right. So some people, we usually what we follow is the sequence. So we debulk the tumor, and first initially we debulk, and then we'll go to the superior, posterior, and inferior aspects. So I'm not going into details, right? So we have already discussed the basics. Right, if you want, you can go through. Right, the hyperostotic bone should be removed and drilled. Tumor extension to the ethmoid sinus, the nasal cavities and orbit should be completely resected as much as possible to prevent the recurrences, because the recurrences usually occur at these places. And if the sinuses are entered, we know the mucosa is accentrated, the sinus packed, dura is grafted, and we usually put a pericranial graft on the floor of the frontal fossa to prevent leakage of CSF. So basically, we had to do a proper skull base, anterior skull base reconstruction. Right. So these are the advantages of bifrontal. The access is good visualization, early disruption of the ethmoidal arteries, especially the hyperostotic bone can be resected very easily and completely. It's a straightforward reconstruction of the skull base. And we can sometimes, if necessary, we can deroof and decompress the optic nerves. There are drawbacks as well. So because of the, we can get cerebral edema or hemorrhage or venous infarction, especially when we transect or the ligate the anterior third of the superior sagittal sinus. So frontal lobe retraction can be a problem. Prolonged retraction can be a problem sometimes. So sometimes it's difficult to release the cerebrospinal fluid early in the procedure because of the initial difficulties in access. And sometimes increased risk of injury to these critical neurovascular structures, because these structures are visualized late during the tumor dissection compared to the pterional approach. So violation of frontal sinuses has its own drawbacks, and sometimes in cases where the tumor is extending all the way to the tuberculum cell, it's difficult sometimes because of the blind spots. Right. So unilateral frontal craniotomy. So you can go for this as well. We don't need to go for a bifrontal approach. You can go for a unilateral approach, which has the advantage of avoiding the all these frontal lobe retraction and superior sagittal sinus violation in the contralateral side. But we need to think that this is more suitable, not in all the cases, selective cases with the predominant unilateral extension. So it has its own drawbacks as well, like small working window and the narrow surgical corridor. So we need to, as a neurosurgeon, you need to plan and do your homework before selecting the approach as we discussed. So as I said, transbasal approach is usually more suitable for tumors extending all the way to the paranasal sinuses and the orbits. And these are the advantages: excellent exposure of the skull base, early devascularization of the tumor. But as we know, we seldom use these approaches nowadays because of the technology. Disadvantages: cosmetically sometimes unacceptable, prolonged surgical time, and the CSF leak rates are high. And then this is the other workhorse for these tumors, pterional approach, usually for small and medium size, but even for the large and giant tumors, you can use this approach. So we all know the technical aspect: Sylvian-Fisher split, sharp dissection, arachnoid membrane, sharp dissection of the arachnoid. You open the opticocarotid cisterns and the release CSF. I'm sure Dr. Dugani will show you in the videos. If necessary, lumbar drains. And the advantage of this approach is we recognize the neurovascular structures early. And so these are the steps. And tumor debulking, devascularization, and then the basics, the strategies. Right. So again, differentiate tumor feeding vessels from end passage perforating arteries. And we had to remember that aggressive coagulation should be avoided. So make your bipolar very, very into a low setting, close to the critical neurovascular structures. I prefer always the sharp dissection. These are the advantages as we talked. Early release of CSF from the cisterns, the opticocarotid cistern, and early identification of critical neurovascular structures, the carotids, the optic nerve, and also the anterior cerebral arteries. So no need of transection of the superior sagittal sinus. Just one frontal lobe is manipulated. Just one olfactory tract is manipulated. So you are sure that the contralateral olfactory tract is preserved. The frontal lobe is preserved, and just one frontal sinus is violated. So it's potential sparing of these structures. But it's not always feasible. In some tumors, there are the drawbacks. So the working angle is narrow, and especially the access to the skull base is limited. And sometimes there are blind areas on the contralateral side as well. So the third approach is endoscopic endonasal approach, which I'm not going to talk about in detail. So this is an excellent option, especially if the tumor is extending into the paranasal sinuses. So it's considered is equal. The outcomes are equal, if not better, compared to the other approaches. Right. So also for the recurrent tumors, it's very good. It provides these advantages: wide ventral corridor, early vascular control, better drilling of the bone, and decompression of the optic nerves without manipulating. And it has a very good near field magnification and visualization. The brain retraction is avoided. So many advantages are there. There are certain drawbacks as well. As we know, the CSF leak rates are high, and preservation of olfaction is sometimes a bit of problem. So optimal patient selection is the key to success in olfactory room meningiomas, right? So these are the complications. We have seen these complications, we have encountered, we have managed these complications: postoperative CSF rhinorrhea, and postoperative seizures, visual impairment, frontal lobe syndrome, loss of olfaction is common. So frontal lobe syndrome, we know the frontal lobe syndrome, and sometimes we see hydrocephalus infarctions due to anterior cerebral artery damage, pneumocephalus. Hydrocephalus may be due to venous thrombosis, infection, ischemia, hematoma, or sometimes normal pressure hydrocephalus we have seen. So we have seen a lot of complications, right? So few facts about olfactory function. So we always try to preserve the olfactory function because considering the quality of life. But as I said, unfortunately, as it's all preservation of olfaction is generally disappointing, whatever the surgical approach is, because even though we anatomically preserve it, sometimes functionally postoperatively we see the function is not there. Right. So frontal lobe manifestations we talked about, visual improvement. So most of the patients they experience a postoperative visual field improvement as well. So when we talked about the recurrence, as I said, recurrence is mainly at the infiltrated skull base bone and also the sinuses. So apart from the residual tumors. So the most important factor to prevent recurrence is the initial extent of the surgical resection. Right. So we'll talk about cases later, and these are the basic few basic facts regarding the technical aspect. So now Dr. Dugani will talk about his experience. So as he goes on, we'll have a further interactive discussion regarding these the technical nuances and the important tips and points to achieve a good outcome in these meningiomas. Dr. Dugani, it's over to you.
Thank you. Thank you, Surat. It was an excellent presentation. You have practically covered comprehensively and scientifically all the important aspects of olfactory growth meningioma. And now, after you presented, it's very little for me left to discuss about this, except showing few approaches and practical aspects of management of these lesions, as you rightly said. I really congratulate you and thank you for this excellent presentation. And in fact, it was very enlightening about these lesions. So we'll go ahead with the practical way of how we do these lesions. And you have very nicely brought out the unilateral approach, bilateral approach, skull base approach, lateral approach, and all that. And we'll just go briefly and see the how it is being done. Now, can I share the screen now?
Sure.
Right. So I'll not go.
Excuse me, we're not saying you're not sharing the screen.
Not sharing the screen?
Yeah. Yeah, you gotta click on one of the images. Or whatever, wherever okay.
Yeah,
Okay.
yeah, we can see, yeah.
Now
You
make
can
it
see now?
presentation. Yeah, make
Go
it
to the
presentation
presentation
mode.
Okay,
Yeah.
okay. Now, yeah, thank you. Thank you. Now I'll not go subsequently into all the aspects because there is very little for me to discuss because it has been extensively covered and discussed by Dr. Sharath. So few important practical aspects when it comes to the management of these lesions. I'll just skip all this. He has mentioned everything. Now, right. In an anatomical specimen, this is how the tumor looks in the brain. That's a post-mortem specimen, a lady with the olfactory growth meningioma. And this is where the location is, and this is how it presses on both the frontal lobes and the backward structures, optic apparatus, carotid arteries, and other structures. Now, the access or the approach is extremely important, as Dr. Sharath mentioned about it. We have a transcranial. I'll just stop the video. Yes. Transcranial approaches, he is already mentioned. We have midline, lateral, and far lateral approaches. And again, these approaches and these accesses depend on the size of the lesion, extent of the lesion, and the growth of the pathology. Next, we have another one is a transfacial approach for these lesions. And the third one is endonasal endoscopic approach. We'll go through those little later. Transcranial approaches, we have unilateral and bilateral. And again, there are specific indications for unilateral approach and bilateral approach, because some cases we definitely do unilateral approach and bilateral. The requirement of unilateral approach is almost about 50% and 50 to 60%, and requirement of bilateral approach is almost about 40 to 50%. So where are which are the conditions when we see on imaging which decide the approach? Small to medium sized lesions and anteriorly placed, and the unilateral extension of the lesion on the one side from the midline and going to the other side. And even though the lesion is large, if it is extending more onto the one side, you can have access it through the unilateral approach. It can be frontal basal approach, it can be fronto-orbito-zygomatic approach, or it can be pterional approach, as Surath mentioned. Next is transcranial approach bilaterally, where we do bifrontal basal craniotomy. Where are the conditions? What are the conditions we do this? That large lesions equally spread on bilaterally on both sides, going laterally and going posteriorly, and with a significant surrounding edema, irregular surface, pile invasion, and going posterior. These are the few cases where we need to do these cases with a bifrontal craniotomy. Sometimes we do get these lesions as an end plaque olfactory groove meningioma. They spread equally on both sides as shown here. That time we need to do a bifrontal craniotomy. Sometimes these lesions go along the forks, even though they are small. Along with the forks, they go deep inside the brain, up to the along with the forks in the deeper structures of the brain. That time again, we may need the bifrontal skull base. That's basic frontal approach. These are few cases. Transfacial and transnasal approaches, when lesion it goes dominantly. This happens in not a primary lesions. It happens in the recurrent lesions where the lesion goes into the paranasal sinuses, anterior and posterior ethmoidal air cells, and upper nasal cavity. It can be midline or it can be bilateral, unilateral on one side. It can be both sides. It can go up to the extent of maxillary sinus. It can go up to the palate, and it can go up to the paranasal sinuses, into the midline, into turbinates, and even go up to the palate. In some cases, I'll show you a few cases. These are the few indications to do this. And what do you need to treat these lesions better? Most important, Professor Surat mentioned already, a cool surgeon, because these surgeries go for a long time. We need to have patience and we have cool attitude to tackle these lesions. We need a good high-end operating microscope. We need a cutting loop, because many times these lesions are firm. A CUSA or a debrider may not work. We need a soft tissue debrider, which is a great tool in firmer lesions where CUSA does not help. Ultrasonic aspirate is the soft lesions. It may be a great help. Neuroendoscopes sometimes we need to use to see the crevices and the places where microscope may not be accessible or reaching there. High-speed micromotor drills, osteotomes, sagittal, coronal, and oscillating osteotomes to have a skull base osteotomy as a skull base exposure, and to have the proper exposure of these lesions. Intraoperative neuroelectrophysiological monitoring is again a great help in treating these lesions. We follow, already Surat mentioned it, we follow 6 Ds when it comes to principles of management. 6 Ds, that is de-dress, a proper craniotomy and proper dural opening and cisternal opening. We call it de-dress. Next important is devascularize, reduce the vascularity of the tumor. Third is debulk, debulk, debulk. That's a mantra in successful excision of all these lesions. Reduce the tumor in size. Dissect from surrounding important neurovascular structures, very important life-threatening neurovascular structures. Deliver the tumor completely, and decorate is very important. That is already he brought it out. Reconstruction of the skull and skull base are important 6 Ds one needs to follow when treating these lesions. So last 30 years, we have treated nearing about 180 cases of olfactory groove meningiomas. Unilateral approaches were 44 cases, and bilateral we had almost 130 cases. Recurrences were in 22 patients. I'll take you to the more common one, a big one where we routinely do, that is bifrontal basal craniotomy, and how we access the lesion. Usually these lesions are conducted through bicoronal scalp flap, preferably the scalp incision behind the hairline, and you raise a flap with the pericranium intact. It's extremely important because at a subsequent stage of the closure, we need to use this vascularized pericranium as a basal graft to avoid CSF leaks and to seal off the face from the skull base. And that's a pericranium is raised. Then we place burr-hole paramedian on both sides, especially in younger individuals, one burr-hole is all right, but in elderly individuals, where we are likely to have the superior sinus adherent to the undersurface of the frontal bone, we need to do 2 burr-holes and either cut it across or nibble it across and make the whole bone is taken out in one single piece like this, as we show. and that's a dura mater, and that's once we do this, what is most important is to remove this bone, that is the orbital and nasofrontal osteotomy. This is of extreme importance to access these lesions to the skull base, where already the lesion is so big, the frontal lobes are swollen and edematous, and they're covering. At that juncture, to lift the frontal lobe or to retract the frontal lobe, it's very risky and dangerous. At that time, if you do the orbital roof osteotomy, anterior part of the frontal lobe, frontal bone osteotomy, frontonasal osteotomy with the oscillating saw or the sagittal saw, the whole frontal bone in the midline is taken up to the frontonasal complex. As shown here, we have done the osteotomy with the oscillating saw, and this is what you get. Now, whole base of the skull is exposed, and the ethmoid sinuses are exposed. This is how the thing looks. Once we do that, it becomes very easy for us. Directly, you are tackling the tumor from the base where it gets adherent or originates from here. This is of extreme importance to have this craniotomies, axis craniotomies. I'll share with you one of the large meningioma, which we operated, a 72-year-old gentleman. 13 years back, he was treated by us for a head injury and a compound depressed fracture of the frontal bone and CSF rhinorrhea, pyogenic meningitis. Subsequently, he developed a hydrocephalus and we put a shunt. In spite of all this, he recovered completely and was doing very well for the last 13 years. And that time, there's no tumor at all. In these 13 years, this time now he presented to us with a headache, abnormal behavior, and seizures and ataxic gait. Now we thought, since he had a shunt, we thought there may be a shunt malfunction and their problems could be because of hydrocephalus. When we did a scan, at our surprise, we had a huge olfactory basal meningioma as shown here, going on both sides, going superiorly, and going up to the vertex almost in the frontal region, and going posteriorly, and significant pressure on the chiasm, hypothalamus, and both the carotid arteries. I can see bilateral extension on this. This is the important is we must have all these cases, the angiogram, the cerebral angiography, either a DSA or MR angiography. We need to see, as Dr. Surat mentioned, the disposition of the carotid artery on both sides, central carotid arteries, anterior cerebral arteries A1 and A2, and anterior communicating artery, and in what relation they have with the capsule of the tumor. Invariably, these lesions are these vessels are shifted posteriorly and superiorly, and sometimes they may get infiltrated and the tumor may encase or engulf these vessels, which makes very dangerous and very risky at the dissection and excision of the surgery. So without doing an angiogram, cerebral angiography is very, very dangerous and risky. And we feel it is a mandatory to have an angiogram and venogram. So this we accessed through bicoronal scalp flap, basal bifrontal craniotomy. I want you to see these are the microplates we used to fix about 13 years back to treat his frontal depressed fractures, and the wound has healed very well. Now, once we do that, next important thing is we did a craniotomy. Sorry, I think there's some problem.
Are you okay?
Yeah, fine, perfect.
Okay.
Okay. This is the bifrontal craniotomy. which we did. And I want you to see the plates, microplates, which were placed at that time to treat the bifrontal, the frontal depressed fracture at that juncture. Now, this is the craniotomy, and the pericranium is elevated, and we make a burr hole, and we, like a Batman's wing, the whole bone on one side is taken out in one piece. Then next we do, this is the bone which is taken out in one piece, as I showed you the procedure. And once that is done, we need to do the frontoorbital osteotomy, which I showed you earlier. The same thing was done. Because of the shortage of time, I thought I'll just skip that. Once that is done, the tumor on one side, on the right side, we open the dura, because already it's a high pressure. Open the dura, go to the base of the skull, and expose the tumor from the base. Either you can open the basally, or you can go on the cortex. I want you to see significant thickening of the dura mater with 2 layers. Now, there is a good plane of cleavage between the tumor and the brain. This is a frontal lobe, basal frontal region, which is elevated, and that's a tumor. Now, you can see part of the basal frontal lobe is gliotic, and that is been taken off. And once you do that, we can expose the tumor very well. Now, I want you to see the tumor capsule is exposed. The normal brain, which is covering the meningioma, is protected with the cottonoids, and the capsule is open on one side. We are first approaching it on the right side, then we'll go out on the left side. Once you do that, always keep coagulating the surface of the meningioma so that the vascularity comes down, and that is done. Internal decompression or debulking of the tumor is initiated. One must remember, as neurosurgeons, I'm sure many of you agree with me, the mantra of excising such a large tumors is to debulk, debulk, debulk. Reduce the tumor in size, reduce the tumor in size, and as you reduce the tumor in size, intracapsular reduction. Once you do that, slowly the capsule starts separating from the surrounding normal brain, that basal frontal lobes on the right side. Whatever part of the tumor you have brought in, you coagulate again the capsule of the tumor and debulk the lesion. This is of utmost importance here. Again, whatever part of the tumor you have brought, again debulk. Debulk, extract, dissect, devascularize, and debulk. These are the repetitive steps which we need to follow. And reduce every stage. You keep on reducing the bulk of the tumor and size of the tumor, because these are very large lesions. One need to go very slowly, meticulously, and do the things. Now we have done the right side. Almost a large amount of tumor debulking is done. And always, you must remember, remain in the capsule of the tumor. It's very important, because we have surrounding, we have important frontal lobe. Basally, we have all the cranial nerves. Posteriorly, we have anterior cerebral artery and the circle of Willis and the optic nerve. Now, start from the lateral aspect of the tumor, separate. Once you do the debulking, tumor starts separating by very easily, comfortably, and you start enjoying the surgery very well. You don't have to worry. You don't have to struggle. Always keep doing that. Now I want you to see there is an olfactory nerve there, which is coming into picture. And always see that the olfactory nerve meningioma doesn't mean the tumor originates from there. It's a misnomer. It is since in the groove of that, it's called olfactory nerve meningioma. It is no way concerned with the olfactory nerves, as Surat mentioned it. It is a vicinity of that olfactory location. So one needs to be very careful, because many times these olfactory nerves are compressed and pushed backwards, and they have arachnoidal covering. Once we do the significant debulking and reduction of the tumor, now we go on to the left side and open the dura on the left side with the dura base towards the midline. Now I want you to see we are opening the dura towards the midline. From the base of the skull is left there, and the normal brain is protected. And again, same procedure from the left side we start. Now you see the frontal lobe again is lifted up and protected with the wet cottons. Now what happens once you do the decompression on one side, the other side brain becomes very lax and very easy. Since the right side, left side is a dominant, we prefer to start the case on the right side first and go to the left side because already the brain is lax. Now we are going to the base of the frontal lobe, frontal cranial fossa, anterocranial fossa. Now I want you to see we are separating the tumor from the base and debulking the tumor from inside. Tumor is very densely adherent to the base of the skull, and capsule of the tumor is open. The same procedures are the steps what we did on the right side are follows again on the left side. Now the capsule is open. See, the importance here is as you keep coagulating the capsule of the tumor, the vascularity starts reducing and the tumor excision again, it becomes very comfortable and safe, and you start enjoying because there is no bleeding. So spending small things like this, devascularizing, debulking, and dissecting are the two steps. Now I want you to see bilaterally we have decompressed and debulked. Now what we will do is go to the crista galli and cut the box in the midline where it originated from the crista galli in the midline. It's very important. Now, once you do cut the fox completely from its attachment from the crista galli, the whole two cavities, right side and left side, becomes one cavity. We started with the right side, we did it on the left side. Now we made them by cutting the fox in the midline and elevating it, both the cavities we joined together. Now, once we start doing that, now we go, tumor starts separating and you go superiorly and posterior part of the tumor, which is extremely important. Once we start doing that, the tumor starts separating, and as Surat mentioned, as you go superiorly and posteriorly, one needs to be very, very clear, very, very careful, always on the lookout for anterior cerebral arteries, A2 and A3, and the subsequent branches of the anterior cerebral artery. They come on the surface of the tumor. Now, I want you to see the tumor has been debulked. Now, we are going to the base. Now, tumor is shifted the vessels on one side. As you keep going, we keep on dissecting it and separating from the frontal lobe. And the vessels from the basal frontal vessels, they supply the tumor and we need to coagulate them and cut them. There will be some amount of adhesions between the frontal lobe and the tumor, arachnoidal thickenings and adhesions, they need to be identified and cut. The separated normal basal frontal lobe is protected with the wet, soft cottons so that during the dissection process, inadvertently, we don't damage them. Now, you see how rapidly the soft tissue debrider is of utmost importance in such cases where QSA may not help, in firmer cases where the cavitation ultrasonic aspirate may not help. It takes a long time. Now, we are going to the base of the tumor now, anteriorly from the crista galli where the fox was cut, and we are going to the basal part of the tumor. Though once we have done a significant decompression, accessing the base becomes very easy and simple, and the tumor starts coming up. This is the place we must remember. We get maximum blood supply from, as Surat mentioned very nicely, it comes from the anterior and posterior ethmoidal arteries. Now I want you to say how large the anterior ethmoidal foramen has enlarged and the blood supply is coming through that. These are the blood vessels supplied by the ophthalmic artery, branch of internal carotid artery. Now we coagulate, that's the origin of the tumor with the hyperostosis and keeps bleeding. We coagulate and with the monopolar, we burn the whole thing so that the cells, tumor cells are killed because of the monopolar cauterization. Now the hemostasis is achieved, the origin of the tumor. We are unable to identify the both the olfactory nerves, as you mentioned earlier. It's very important. We may not, in a large lesions, they get damaged, destroyed, or sometimes by the tumor or by our dissection itself. One need not worry because already he has an anosmia. Try to look for it and try to preserve it. If not, it's okay. But sometimes in our experience wise, I have preserved more than 30% of the time unilateral and about 6 to 10% of the time bilateral preservation. In this next video, I'll show you the preservation of olfactory nerve. In this case, we could not save the olfactory nerve because of the dense adhesions, because of the trauma and meningitis and large lesion. Now we are separating the tumor from the basal regions. And as you go basally towards the midline or posteriorly, always keep looking for the anterior cerebral arteries, that is A1 and anterior communicating artery on the both sides, and optic nerves on both sides, and optic chiasm in the center. One always needs to look for that. Now we dissected. Now I want you to see both the anterior cerebral arteries are coming into view from the deeper and posterior part of the tumor. Then you stop again. Again, you debulk the tumor, superior part of the tumor, because once you know where the anterior cerebral arteries are located, it's very comfortable and easy for where the thief is, and you can catch him, or you can pardon him from all around and catch him. So once that debulking, further debulking is done, you get some space. Now I want you to see the anterior cerebral artery A2 so densely adherent to the capsule of the tumor. Again, this is only possible if you have a good dissection from the surrounding. Now from the capsule, the blood supply comes from the ACA, is coagulated, and the ACA, that's anterior cerebral artery A2 and A3, are dissected free from the capsule of the tumor on the one side. Now the remaining in the arachnoidal plane, the opposite side ACA is also shifted towards the left side, and the tumor is taken up along with that. Now the whole tumor with the capsule is excised completely. Once we do that, now we are now seeing the A1, there the thickening of the arachnoidal membrane. That's a membrane of Lilliquist, which is there. You can see through that, and you can see the A1 on the left side, A1 on the right side, and that is optic chiasm, which is now coming into picture. This anterior communicating artery, and this is the A2 going posteriorly. This is extremely important because if we damage any one of these anterior cerebral arteries, patient may have devastating neurological deficits, paraplegia, behavioral abnormalities, bladder dysfunctions, so many other, the higher function abnormalities will come. Now you see the membrane of Lilliquist is opened. You can see the basilar artery there. Behind posteriorly, and you can see the pituitary stalk in the center there. And that is the complete excision of the lesion with the preservation of all the important skull-based structures. Surat mentioned very nicely. This is the end stage of the surgery here. You can see the chiasm, you can see the vessels, you can see the basilar artery, circle of Willis, and the optic nerves and optic chiasm. Next important step is to achieve absolute strict hemostasis, because there's a very raw area, a big tumor, and you must maintain the blood, the hemostasis. We ask the anesthetist to raise the BP, wait for 15-20 minutes, and confirm there is no bleeding. Then dura mater is closed, as much watertight as possible, because as he mentioned earlier, we may have opened the basal systems, frontal air sinus. Patient should not have CSF rhinorrhea, which is very common in these lesions, and subsequently may develop pyogenic meningitis, which may be very dangerous and risky. Dura mater is closed. Sometimes we need to use the pericranium to close the dura mater. Now the dura, once you confirm the dura mater closure, frontal sinus is closed, the bone is replaced and fixed. This is a post-operative clinical condition on day 5. He is ambulant with no neurological deficits, and this is the histology confirming type 1, the myxoid type of meningioma, basal meningioma of the olfactory groove meningioma. This is the end stage of surgery. Now we'll go through a few of the important issues once you go. Now this is the craniotomy, how we close it. The bone with dust, which is collected during the craniotomy, we collect the bone dust always. And all the burr holes are covered with this bone dust, and the craniotomy cuttings are covered so that patient doesn't have the scar and the depression on the forehead. And after the surgery, after some time, the bone is fixed with the microplates. This is CT scan brain on day 2, complete excision of the lesion. There is no hemorrhage, no edema, no infection, no infarction. Ventricles are normal. You can see the old shunt tube, which has been placed earlier and working very well. That is the complete excision and end stage of the tumor. Next important, as we sort of mentioned, and I mentioned to you earlier, preservation of olfactory nerves is of utmost importance. If for some cases, you can do that when the tumor is small and posteriorly placed and the dissection is done well. Now you see the tumor is separated from the basal region and part of the tumor is cut here and taken out. Again, the dissection has to be arachnoidal dissection. And remember that these nerves have a good arachnoidal plane on them and you can keep looking for them. Now the tumor capsule superiorly is separated and dissected and tumor capsule is taken out completely. Now I want you to see that it's the posterior part. And we have protected all the vessels. Now, once we do that, I want you to see the olfactory nerve on the one side where the tumor was smaller comparatively on the right side. Now that's the olfactory nerve preservation. You can see that completely well preserved, at least on one side. And we don't know, as mentioned, how much functionally it is going to be, but better to keep it so that in future date, we may have, we don't know whether he develops it or not. Next important thing he mentioned in his presentation is skull base reconstruction, because these lesions, they grow in the skull base along superiorly and inferiorly because they're in between that. Then once the skull base is breached, it is very important for us to reconstruct the skull base. It's of utmost importance. Large olfactory groove meningioma, eroding the wide skull base from anterior to posterior and more of it superiorly. Now again accessed through bilateral frontal basal pneumotomy with frontal osteotomy. Lesion, the frontal nasal osteotomy lesion is taken out completely. I want you to see now a large defect in the base of the skull, anterocranial fossa. The dura mater here, most important is the basal dura mater must be closed under any circumstances if you want to prevent CSF leak and pseudomeningocele and herniation of the brain sometimes into the defect and getting into the upper nasal cavity. So dura mater has to be closed either with the pericranial graft or with a fasciolata or an artificial dura. It's done and microplates are used. Now, another important thing I wanted to show you, to reconstruct the skull base, we harvest the outer table of the skull, very easily available there. Just behind, you open push the skull back. The size of the defect you want to close, you can harvest a square or round or whatever with an oscillating saw and sagittal saw, and you can harvest a bone and you can use it as a graft to create, to have a bony closure of the skull base completely when it is eroded by the tumor. And you can have vascularized pericranium, which is you have preserved during the craniotomy. It is brought back and layered on that as a carpet, and the reconstruction is done. This is the complete excision and the reconstruction of the skull base. Next important comes is, as he mentioned to you earlier, recurrences of these lesions is very important. And these recurrences, again, he mentioned very nicely, they majority of the time recur either into the nasal cavity, oral cavity, or paranasal sinuses, and where you need to operate these lesions. This is one lesion, olfactory groove meningioma we excised. 7 years later, we have missed that tumor going into the skull base. So I think 9 years later, I think it came back. Now you see the tumor in the cranial cavity here, a small tumor in the base. You can see here where we had operated earlier, a small tumor here. Major recurrence is in the nasal cavity, upper nasal cavity, almost reaching up to the palate here. You can see the whole tumor. This we decided to access through the endoscopic route, because tumor is predominantly the nasal cavity and a very small component of the tumor is intracranial. So first we went endoscopic forehand technique with an ENT help. Tumor was accessed and this tumor is debulked endonasally and endoscopically maximum extent. We were hopeful and we were sure that we may pull this part of the tumor down through the endonasal route only, and we may not be able to, we may not go transcranially. But for our bad luck and our surprise, tumor is very firm and densely adherent to the base of the anterior cranial fossa and tuberous. See, look at this. It's not coming down at all. And there are tremendous adhesions all around the tumor. So we debulked completely, flush with the anterior skull base as shown here. Then subsequently, what we decided is closed at that level, put a pack there and opened this transfrontal approach, basal frontal approach, unilateral approach here, as you see, and we accessed this part of the tumor from the frontal region. This is unilateral frontal on the right side. I want you to see the tumor is very firm. Again, not coming into ultrasonic aspirate. We had to use the soft tissue debrider and debulk the tumor and excise it. Now that is the posterior frontal part below the frontal lobe, which is the tumor is being debulked and dissected, and whole tumor is taken out completely here. Now, once I want you to see here, this is the recurrence of the tumor, and that recurrence of the tumor has gone paramedially on one side of the midline. Now, the tumor is still there. I want you to see the tumor is still there. And if you leave it, again, you'll have recurrence. So we decided to have a radical excision. That's a part of the tumor. This is where we use a debrider, and whole base of the anterior cranial fossa and midline are excised. Now I want you to see, we took off the gauze from superiorly, which were placed in the nasal cavity, endonasal approach. So once we do that, the whole surrounding tumor part is debulked and excised. Now endonasally, we pass the tube, the endoscope nasally, and we are watching through nasal cavity. This is a microscope light from superiorly, and we're watching this endonasal endoscopically. We're watching this. Now I want you to see from both the cavities are communicated with each other, and we can see the light coming from the below. And sorry. Now you can see the face of the surgeon there and the hands of the surgeon. From below, you can see that. Now we had to do the reconstruction, as I mentioned to you earlier. This is a little very interesting. I will just go through that. Now that endoscope you are seeing from the microscope light, and this is endoscope light. So both the cavities are made into one, and this is a large defect we have created in the base of the skull. Now you see the hands of the surgeon. We are seeing from below, that is nasal cavity, through the endoscope, and you can see the face of the surgeon. You can see the face of us from the nasal cavity. Through the defect, we can see our face also. So that is the cavity created between the skull, the frontal skull base. Now we have to repair it under any circumstances. As I mentioned to you earlier, we take a skull part of the skull and split it depending on the size of this bone you want, and we trim it. And we use it as a bone reconstruction and put a microplate and reconstruct the skull base. It's of utmost importance to do that. Otherwise, then we take a small fat from the fascia lata or anterior abdominal wall and put it all around, as you see here, and take a vascularized pericranial graft, which we had left there, and use it as a carpet on the surface of this. Then we go down, we fix the bone and close the craniotomy. We go down here and same graft is again put there. The bone, you can see, fat is taken out, part of it was taken out, and we seal the defect with the tissue seal and have as much as watertight closure as possible. This is the patient post-operatively and perfectly normal, and that is the post-operative condition of the patient. Transfacial, this lady had a big meningioma. Again, I want you to see, we operated almost 18 years back transcranial, and whole meningioma has excised olfactory groove. Now I want you to see, she came back almost about 18 years later. The recurrence, a big recurrence. Now you see the recurrence is not here. A small recurrence there, small recurrence here on the convexity dura, basal dura. The whole tumor has occupied the nasal cavity completely, resting on the palate and going into the nasopharynx and obstructing her airway. This is what it is. So this one we decided to go endoscopically. It was very firm and not possible, and we decided to go through the maxillofacial. Friends, I want you to see the tumor coming into the nose on the left side. This was the very firm tumor. So we decided to go through the help of the maxillofacial colleagues through Weber-Ferguson incision, transfacial, and complete removal of the lesion. This is the Weber-Ferguson incision, midline facial split, and palatal osteotomy. And this is the lesion. This is a tumor there, which is coming out through the nasal cavity, nasopharyngeal cavity, and upper nasal, all sinuses, including the maxillary sinus. The complete excision of the tumor is done, and tumor is literally taken up to the skull base, as you see here. And that is the end stage of surgery. The whole tumor is taken off. And the most important is to reconstruct the face. Now you see the whole tumor is out from the nasal cavity, taken out completely, and posterior part is taken. Most important is to now to reconstruct the face is of utmost importance. We use the microplates and reconstruct the face, and that is the state of after 2 weeks of the tumor excision. These are the different approaches. Approaches in cases of different recurrences. So complications always there, and if you keep operating, always you'll have complications which are not in our hands. It's a nature which creates some problems, and tumor creates some problems. Sometimes we create problems for the patient. We need to identify and recognize them and treat them, as Dr. Surat mentioned very nicely, majority of the complications. And believe me, all these complications, if you keep in mind before surgery, and you can definitely look for them. That's what they said in English, unless the eyes won't see what the mind doesn't know. So you have to know all this can happen. And when it happens, you are strong enough and good enough to treat these complications very well and quite safe. I think that's the last slide. Thank you very much for your patient hearing. And I think I've taken much of your time. And I thank Professor Surat and my good friend, John Bennett, and Neurosurgical TV, Sri Lankan Neurosurgical Association, South Asian Neurosurgical Association for the excellent time and opportunity to share and learn from each other. Thank you very much.
Thank you very much, Dr. Dugani. I think it's a fantastic, I mean, I have no words to explain. Excellent presentation. It's very beautiful. And I think we have a lot to learn from you with your vast experience, because we have seen your previous videos in the web. I mean, we have seen you operating large tumors, massive tumors. Always you like to operate these huge tumors with, you know, very less complications. So I think most of the time, I very much appreciate your techniques, your beautiful dissection, your thought process, the patience, and more importantly, the successful outcome of your patients within few days. I have seen. So I mean, it's very satisfying to see you operating and to see your great outcomes. So I'm very much grateful, and thank you very much for coming on board today. And I hope we can continue this, so we can learn from you a lot. I think it's a big I mean, it's a big help to I mean, the residents and even the experienced neurosurgeons to learn from you, from your experience, the tips, and to how to overcome the difficulties that we encounter. I think it's a very, very big advantage for all of us to learn from you. So before we wind up, I think there are a few questions that I would like to ask from you regarding olfactory groove meningiomas.
So before that, I'm thankful to you for your compliments and for your good words. I hope to leave up to your expectation. We always try that. And you have been marvelous in your presentation. You made my presentation very simple and easy, because already you covered the hardest part of the presentation. And I'm thankful to you and Professor John Bennett for this excellent opportunity, sharing and learning from each other. Life is just like that. Not that I know everything, you know everything. No, you know something good, I know something good. We share and learn and become wiser. And ultimately, we transmit this knowledge and information to the betterment of humanity. Ultimately, see, me, you, John, everybody, all of us rotate and revolve around our patients, who is our God. And for his benefit and for his goodness, we strive hard. And you are doing marvelous job. This John Bennett is an excellent job in the education of our field. Thank you, Surat. Thank you again. Please go ahead. Go ahead.
Yes, you're welcome. I cannot agree more than that. So I think that attitude and the thought process is more important for a neurosurgeon, more than the skill. Right. So I would like to ask first, what is your experience regarding the pterional approach for large and giant meningiomas? So I hope you prefer the bifrontal approach, but what is your experience pterional approach in giant meningiomas?
You mean to olfactory groove meningiomas?
Yes, yes.
Yeah. Surat, I must really confess, somehow I am not very comfortable and happy approaching these big lesions from the Sylvian and pterional craniotomy. Because what happens is, if the lesion is quite, you said, a big one and a giant one, and again, what happens here, the brain is swollen and edematous in many of these cases. To access and to reach these lesions, we may have to the small craniotomy of pterional craniotomy, that we may end up injuring the brain, number one. And the depth, when it goes to the opposite side, the depth becomes too difficult, too much long to excise the capsule from the opposite side, number two. Number three, the anterior cerebral arteries, which go on the superior surface of the tumor, becomes a little difficult to access and to dissect from this side. There are few of my colleagues, they keep doing it, but ultimately, I think it is the technological mastery which they have got. But I feel not very comfortable to do this. I have not done many cases of giant olfactory groove meningiomas through pterional craniotomy.
Right. We have a question in the chat box. So since it's relevant to this question, I will ask you that as well. So it is from Dr. Obaid. He's asking, most of the surgeons hesitate to drill the floor of the tumor because of fear of CSF leakage. So he's asking your advice, when to drill and when not to drill.
Yes.
And yeah, and he's asking whether the vascularized pericranium is always necessary.
Thank you, Surat, and thank you, Obaid. You're absolutely right. See, when at the end of the surgery, when you inspect the floor of the anterocranial fossa, two things happen. One, preoperatively, you're already aware, preoperatively, the skull base is eroded. Already you're aware. And many times, a few meningiomas come with CSF rhinorrhea as a clinical presentation. Right. That's one aspect of it. Already there is erosion. Preoperatively, you are aware of it. Number one. Number two, when you excise the meningioma completely and flush with the anterior skull base, the dura mater on the base of the skull and the tumor what was attached, it looks very thickened, irregular, granular, and vascular. So this thing tells you that yes, there's a tumor is there, and you should not stop, even though the bone is involved, eroded, to drill this bone, drill the tumor, and take it out completely, because we do have various ways of reconstruction. Now, if you leave the tumor and come off, two things happen. It's going to have a CSF leak and tumor is going to recur. That's a second question. So we must go ahead and drill the anterocranial fossa and burn the whole tumor and come out and reconstruct the skull base, right? Third question, you asked pericranial vascularized graft is all preferably better because it's quite a wide and a large carpet. We call carpeting, carpet the anterocline fossa. Put a carpet on that. It is, if it is a vascular, the survival of this graft is quite good. And we have wide space. Number two. Number three, there is no breaks in this vascularized pericranial graft, so that it is one sheet of the tissue, which really helps in reconstructing skull base and prevention of CSF leaks. So preferably vascularized. And during the craniotomy, you raise it and keep it at the along with the flap. That's what.
Thank you very much, Dr. Dutta. Yeah.
Excuse me,
Yes, John.
Suresh, we have a question from Samuel Kaba. Samuel, do you want to ask that question directly? So you get to meet the surgeon?
Yeah, sure, I can do that.
Go ahead, Samuel.
All right, so I was kind of wondering, thanks, Dr. Suresh, for such a wonderful job that you're doing, and I think that these are masterpiece. Now, with the huge meningiomas, the giant meningiomas, how many hours do you spend in doing them? And have you ever considered staging them, or have you done staging to reduce the number of hours? And what would be the results in that? Thanks.
Thank you, Professor. It's Professor Samuel Kaba. It is a very, very important question. Very important question. It is the question of all of us, all neurosurgeons. You know, it is a very practical question what you have asked. Yes. See, on an average, we operate a formidable vascular irregular surface firm lesions on MRI scan about 6 to 8 hours. We go ahead and take it out 6 to 8 hours. We have not crossed more than that in last about 15 to 20 years. Number one. The second question you asked about staging of this meningiomas. Go in the second. A very important question, and I really like it what you have asked. Yes, a lesion where the preoperative image showing extensive brain edema, number one. Number two, the irregular surface of the meningioma with the multiple irregularities on the capsule of the meningioma. Third, intense enhancement of the meningioma. And fourth, going superiorly and posteriorly, number five. Number five, during the surgery, you getting a lot of vascularity, lot of dissection difficulty, and sometimes the frontal lobe starts swelling. You must stop, and always remain in the capsule of the tumor, inside the tumor capsule. Debulk, and you feel that going is going to be tough and difficult, stop at that. I agree with you. And maybe 3 months down the line, again, the nature is so good. I have seen with my experience. I have done more than about 20-25 cases as a secondary staging. Again, the nature is such a good help to patient and to us. Once you have done the significant amount of debulking of this tumor has reduced in size, and the area between the tumor and the brain becomes loose. And because of the brain pulsations, the tumor which you are debulked, the tumor will be pushed down and anteriorly. And when you go second time, what difficulties you faced during the first time, you will not face anything, and safely and comfortably you can excise the tumor.
I do agree with you because we stage a lot. I tend to stage a lot when they're,
Yes.
And I always, even tumors that initially with the CUSA, they bleed
Yes.
a lot. When you come in the second phase, they don't. But
Exactly.
just a follow-up question. Do you use spinal drain in some of the tumors?
No, we don't use. We don't use. Thank you.
Thank you, Sam, and thank you, Dr. Dugari. So, since he raised that question, I just want to show you one of my cases. So, if you see this tumor, so this is 3 years back when I was in a peripheral hospital in Eastern Province. So, you can see I don't have the MRI facilities there. So, this young lady, 32 years of age, young lady, presented with headache, visual disturbances, and uncontrollable seizures, and psychiatric psychological impairment. So you know, in some part of my country, people are a little bit ignorant, so they go and do this what you call this local treatment, this Ayurvedic treatment, and they don't want to get operated. So this is such a case that they have gone for this primitive treatment, and her family is about to disrupt. So I had no choice. I had to operate this case even without an MRI. So I didn't have the facility to even go for an angiogram at that time. So you can see it's a very huge, I mean, large tumor. And I operated with this CT. So it was very tough, and I didn't have the CUSA as well. So I was just using these micro scissors and the bipolar. The tumor was absolutely firm, and it was very severely, adherent to the anterior cerebral artery complex. So it took me around 6 hours for this operation, but luckily I could take out the whole tumor, and she did very well, and her psychological disturbances all resolved. So I mean, these are the difficulties that we encounter sometimes when you don't have the proper facilities. So this is another case. Again, a large meningioma. So again, I did not have the MRI. I'm sure, as you said, angiogram and MRI is a must for these type of tumors, which are advanced and complicated, and sometimes give you devastating complications if you don't identify the anatomy. So another case, so all these patients did very well, so they didn't get any complications. So the anterior skull base reconstruction was done. So these are the challenges, and these are the technical challenges that we encounter sometimes, especially working.
Just wait, the bandwidth will catch up. Usually we wait these delays out.
True.
Well, perhaps Takashi, while we're waiting, Takashi Khan, he's a neuro-oncologist from Japan, a frequent visitor and supporter of this platform. Welcome, Takashi. You have any comments or questions for Dr. Dugani?
Yeah, thank you, Dr. Dugani, for a wonderful presentation and about the olfactory, as for olfactory groove meningioma. So it's very difficult to remove totally, and since the olfactory nerve is very fragile, so very difficult to preserve. And as for, I'd like to ask you one question. So are there any, in your case, are there any frequency of malignant atypical meningioma? In that case, so reconstruction is more detailed, and reconstruction needed. As for atypical, as for malignant, atypical or atypical malignant meningioma, so additional treatment is needed in your case?
Yes. Thank you, Professor. It is very important and nice question. Yes. See, when you send histologically these lesions, our neuropathologists, they grade the meningiomas according to the World Health Organization grading. Right. We have had grade 3 and grade 4 cases, about 18 cases, or 18 or 20. I remember that. Number one. Second category, your question is extremely important. Second category of meningiomas, we call them as hemangiopericytomas.
Yeah.
Hemangiopericytomas. They are highly vascular and highly recurrent. They keep on recurring and difficult to excise. We had about more than 22 or 24 cases of hemangiopericytomas. So whenever there is a pathologist gives us that, yes, there is a grade 3, a grade 4 WHO, we send them for radiation. Even though we have taken out the tumor completely, we send them for radiation. Hemangiopericytomas, again, if you have taken out completely, we wait and watch. Otherwise, we send them for radiation. Radiation is an extremely important tool in these lesions. Number 2. Number 3, if your remnant tumor, if you are left behind, say the tumor is adherent to the anterior cerebral artery, anterior communicating artery, or the carotid artery, or the optic apparatus, then we send them for gamma knife.
Again, yeah.
Gamma knife.
Thank you.
Radiation. Yeah. Thank you.
Okay. Thanks.
Do you see
Yeah,
any more
I
questions?
think.
Go ahead.
Yeah, I think I lost my connection, so I don't know whether you.
It's okay. Welcome back.
Yeah. So I don't know whether you saw my cases when I shared the screen. Let me share it again. So I was just talking about these type of large tumors. So now the problem for us is sometimes we don't have the facility to do the MRIs and the angiograms sometimes. So this is a similar situation I encountered 3 years back. So the huge tumors. So we did not have the MRI facility, but I mean, there was, no option. I had to go through.
Excuse me, Sarath. I'm sorry, I'm not a neurosurgeon, but I have a question. What would an MRI show that a CT would not?
As we discussed, the MRI, we give you the more information regarding the anatomical delineation, the edema, the amount of edema, the pile invasion, and also the relationship of the blood vessels, especially the anterior cerebral complex to the tumor. From CT, it's a bit difficult, but CT angiogram, at least we should have a CT angiogram, as Dr. Dugani mentioned, for us to appreciate the relationship of the blood vessels to the tumor. So I think in these complicated cases, complex cases, I think we always try to have an MRI. But in some countries, in some countries, third world countries, it's not available. So we have no option rather than, sometimes you have to go ahead with the with the resources that you have got.
Right.
So this tumor was very tough, as I mentioned. So it took me around 6 hours to take this out because I didn't have the CUSA at that time. So it was just with the microscissors and the bipolar, and the tumor was really adherent to the anterior cerebral artery complex as well. But fortunately, I was able to separate it from and take the whole tumor out. So the patient did very well. So it's not just one case. I had several cases. So I had no option rather than going ahead with surgery because of certain concerns. So what is your advice, Dr. Dugan, in these type of situations? Because sometimes we encounter these problems, when the tumor is tough, because the CUSA is not very helpful sometimes. So I have seen you using the soft tissue debrider, but soft tissue debrider is not available for most of us.
Yeah, true. No, I'll tell you what. Very nice question, Surat. See, as you rightly said, this type of tumors, many times ultrasonic aspirate CUSA will fail us. It won't help us in any way. Now, next important thing what you can do in these cases is cutting monopolar loop. Cutting monopolar loop. You got it. It is a loop in the long loop. That will help you rapidly to cut the tumor and decompress and cut and coagulate at the same time. Now, Now, if you look at the cost of the ultrasonic aspirate, that's CUSA, Caudron ultrasonic aspirate, the cost of the CUSA and the cost of the debrider. Cost of the debrider is 8 lakhs rupees, Indian rupees. The cost of the CUSA is 30 lakhs Indian rupees. So 3 times more. So debrider will help in all the situations. So I usually prefer to have a debrider at a low cost and helpful compared to ultrasonic aspirate. Cutting loop is again of a great help, number one. Number 3, the internal decompression with suction and bipolar. Bipolar, keep it at a high intensity inside the tumor, high intensity. And as you keep debriding, keep coagulating the capsule, surface of the capsule. There, the blood supply to the tumor starts coming down. There are a few things which we need to follow them.
Yeah. And also, I think when you are operating under those type of circumstances, I think it's always, we should think about the patient safety first. It's always advisable to keep a sliver of tumor close to the vital neurovascular structures rather than trying to remove, completely resect it with your ego.
Yes. So that another important trick, the tip, it's a practical tip. What we do is, we ask the anesthetist to bring down the BP in these people. Say his induction BP was 120, 130. We ask him to keep it at 90 to 100. Number 1. Number 2, we give injectable hemostatic agents. Tranexamic acid and PAUSE and all those. They do help in to some extent in reducing the bleeding and keeping the field clean.
Yes.
Younger the individual, you can bring down the BP up to 80 to 90 in a crucial phase. You can ask the anesthetist to mind. That's what we follow it. And another tip for that too, vascular lesions.
Right.
Thank you. We have another question from Fayez Obaid, who's a neurosurgeon from Jordan, from Amman and Jordan, home of Ibrahim Sabea. He asked, do you do chromosomal SND genetic study for all cases of meningioma?
Yes. Yeah. Thank you, Professor John. Yes. Last about 3 to 4 years, our histopathology department, neurohistopathology department, NIMHANS, that's National Institute of Mental Health and Neurosciences, all tumors, they are doing genetic as well as immunohistochemistry. All studies are being done. Genetic chromosomal analysis. About battery of tests are there, about 8 to 10 genetic markers. They study those things. Last about 3 to 5 years.
Thank you.
Thank you.
All right. So I think we have okay. Go ahead, Samuel.
Let me just ask a question because ultimately one of the things in these kind of tumors is the use of spy agents like fluorescein and methylene blue and all that. Do you have any experience with that? I have used them frequently these years, and sometimes I don't really see a big difference when it comes to certain level of tumors. And also to contribute to the issue of the CUSA, I've actually operated over 20 years without CUSA, and now I'm operating with CUSA, and I'll tell you the difference. When you meet a bleeding tumor, it's just not helpful. It tends to bleed more and more and more. And the cutting loop or the debrider is even far better than using the CUSA. So for a lot of young people, talking of CUSA is like something super good, but it's not actually useful in many tumors. It's just some selected tumors that you can use. And cost implication, I'm from Ghana, right? And we don't have that luxury of patients being capable of paying because everything is out of pocket payment. And you can actually keep patients on a very lower point with the minimum that you have. And I think it works pretty good for us than to one super things that are expensive for patients and they actually don't serve too much of the purpose. Thank you.
Yes. Agree with you. Very, very important point what you have brought to process handle. 100% agree with you. This is what you want to see. Our country is also no different. All of our Asian countries, majority of them are, except Japan, Singapore, China, Hong Kong. I mean, they are much advanced technologically and infrastructurally, but majority of us are almost more or less the same level we are working in. Ultimately, your own skills, your own attitude matters in these issues, as you rightly said.
Completely agree. I also completely agree with you.
That's right. That's right.
Right. I think so, John. I think we can wind up if there are no more questions.
Yeah, very interactive. Thank you, Dr. Dugani. That's what we like these webcasts to be. Like Sarath and I have talked about it, but
Yes.
to have people involved and asking questions is tremendous. And this was a good teaching.
Discussions.
This was a good teaching episode, and that's what we're after: teaching.
Thank you.
So,
Thank you. Regarding the next topic of Fox meningiomas,
Yes.
sometime next month we can plan it. We'll plan it.
Of course. Yeah. We can plan it in 1 month's time. So we can discuss both parasagittal and falcine meningiomas together.
Meningiomas, yes.
Okay,
It's a very
great.
important topic. Very important.
Okay, thanks, Takashi. Thanks, Samuel, for coming from Ghana and Kenya. And we'll see you at the next webcast.
Yes.